It's my pleasure being here, of course, and what led us to the MR-Linac is the wish to see what's going on in the patient during the treatment itself. And you cannot see all the structures that you want to avoid with CT imaging. You cannot see during beam delivery, but with MR-Linac you can see all the structures, and you can see it while you are delivering the radiation. And that wish brought us to, okay, let's see if we can bring these two machines together, an MR scanner and a linear accelerator. And that worked out in the end. Yeah, we started, of course, initially with sites that were not visible with X-ray modalities. Think about pancreatic cancer, renal cell cancer. But in practice, the prostate cancers were the main driving patient categories on the MR-Linac, because it's one of the big patient populations in our region, and you can make quite an impact there because we can reduce the number of fractions for these patients. So we have now a non-invasive treatment of only a few sessions for these patients, which is very cost effective but also very patient friendly. Yeah, absolutely. I think that there's a need for faster workflows because it's more efficient, but also it's more comfortable for the patient because you don't have to lie so long on a table. And it is already going on. There's more automation in the treatment planning, there's more automation in the delineation of structures that needs to be sped up, and also the tools of evaluating all these automatic proposals. That's something that needs to be worked on. But again, that's research in progress, and it's going step by step. But the proposals are getting better. The automatic proposals we use now, if you compare it to years back, that's really a world of change. Now, the thing with highly mobile tumors is that you can try to predict upfront what will be the motion and take that into account, but it might vary during the course of treatment. And with MR-Linac, you can see that, and if you see it, you can do something about it. So you can adapt for these kind of changes in motion. And that's what the big promise of this machine is, of course, that you can see what's going on. If it is not what you expected, you can adapt the treatment, and that's for motion patterns, that's for geometrical changes, that's for all kind of alterations during the course of treatment. You can take that into account, and you can optimize the treatment for that. Now, I think that there's two big trends coming up. One is that there will be more adaptive treatments done in radiotherapy, so we will adapt more frequently because it's going to be faster and more automated. And then the other trend, which I hope is going to be a trend, is that this will provoke a discussion with invasive treatment modalities. So can we offer radiotherapy as a non-invasive alternative for certain surgical indications? Prostatectomy is one thing that comes to mind. Nephrectomy is something that comes to mind. Can we offer an alternative for these kind of patients? Pancreatic cancer, can we, instead of doing a Whipple operation, offer for local control a radiotherapy treatment? And that's something that we have to explore. And I really think there's good opportunities there, but it's a very difficult and delicate process to get started. But we have the tools now, and we can do it, and we have to make the clinical studies. I'm very impressed with the whole setup of the conference, and the amount of people, the amount of faculty. It's very big, and it's as far as I've seen, it's pretty comprehensive, covering the whole oncology field. So I think that's a very worthwhile setting to discuss this. And yeah, I have no insights in how this will be disseminated throughout the rest of the country. But it seems that it's so big that you have enough power and participation to disseminate to the rest of the oncology field. I think Apollo should take its responsibility and also start a training center for MR-Linac. There is a learning curve. It is a new technology, and it is a new mindset to do more adaptive radiotherapy. And then I think India can benefit from this massively because of this hyperfractionation. It's much more efficient, but someone needs to drive it, and I think there's a very nice opportunity, both cost-wise and also impact-wise, for Apollo to make a difference here. So that's my plea to Apollo, basically. Do it and make sure that you also introduce this technology into India. Thank you.